You are connected, and you are listening to Specifically for Seniors, the podcast for those in the Remember When generation. Today's podcast is available everywhere you listen to podcasts and with video at Specifically for Seniors YouTube channel. Now, here's your host, Dr. Larry Barsh.
My guest today on Specifically for Seniors is Sorell Schwartz. Dr. Schwartz is Professor Emeritus of Pharmacology at Georgetown University Medical Center. He has served as Professor of Pharmacology at Georgetown University School of Medicine, Senior Pharmacology Advisor at the U.S. Food and Drug Administration, the head of Pharmacology Division at the U.S. Naval Medical Research Institute, and has had advisory appointments at the National Library of Medicine, the FDA, the EPA, the National Institute on Drug Abuse, the FTC, the U.S. House of Representatives, OSHA, the Department of Defense, the FBI, and WHO. Welcome to Specifically for Seniors, Sorell.
My pleasure, Larry. Thank you.
During the pandemic, two U.S. agencies were mentioned continuously, and some listeners to the podcast mentioned that they were confused about the difference between the CDC and the FDA and the interrelationship between the two. Can you clarify that for us?
Well, both agencies are agencies of the Department of Health and Human Services. The FDA is a regulatory agency, and it regulates food, drugs, and cosmetics. Now, it doesn't approve a grade A steak, but it approves any additive added to that steak. So the safety of foods has mostly to do with food additives. Also, if you have a paper in which you're wrapping food for a freezer or something like that, and there's some chemical component of that paper that also needs approval of the FDA. But it is regulatory, meaning that it sets the rules for what drugs can be on the market, whether they are prescription drugs or whether they're over-the-counter drugs. They also approve devices such as anything for the heart or anything that's generally indwelling. Doesn't have to be indwelling, but all devices have to be approved by the FDA. The CDC, on the other hand, is not a regulatory agency, but it is an agency which actually sets sometimes advisories and sometimes requirements. For example, we go back to the COVID-19. The FDA had to approve the safety and efficacy of a vaccine, but the CDC established who gets the vaccine. Somebody over 65, not children under 5, and so forth like that. The CDC has some authority, advisory, and some of it statutory, that allows them to make certain decisions regarding something affecting public health. So again, in drugs, for example, it can, if there is a reason to restrict the use of a drug, in this case a vaccine, which comes under the FDA, they can set those requirements, but they can't set whether or not it is safety or efficacious. That's required by the Food and Drug Administration. So they're both agencies that, and by the way, there was the question you ask, and you say that people were confused, that's interesting because I think even the government itself was confused because they have a memorandum of understanding between the FDA and the CDC, not from 1980 or 1990, but from June of 2022. So uh, there, there is an actual memorandum of understanding that shows where they have separate responsibilities and where they have overlap in responsibilities. And the CDC is the major contact or liaison between the U.S. health system and the World Health Organization.
This podcast is directed mostly at older adults. What are the specific issues with medication use in seniors, in older adults?
With seniors in particular, we have a number of issues uh, that are specific to older adults. First of all, appropriateness, where you say, well, is appropriateness an issue with everybody? Yes, but um, unfortunately, when clinical trials are done to establish a safety and efficacy of a drug, the elderly generally, frequently, usually are not included in these clinical trials, especially people over 80. So uh, it may be, for example, that a woman in her late 80s has uh, a breast tumor removed. There's not a great deal of data on what type of chemotherapy is safety and efficacious for someone of that age. That would be a follow-up, let's say, to having that tumor removed. So that's the problem. Also, the problem of the elderly is that people over 65, and especially over 80, if they make it that far, are generally suffering from multiple medical issues. And multiple medical issues mean generally multiple physicians. And multiple physicians generally mean multiple drugs. And that's what we call polypharmacy. Polypharmacy is the use of multiple drugs for the purpose of treating. It could be treating one condition, but generally it comes about because you're treating high blood pressure, you're treating metabolic syndrome or pre-diabetic or diabetic, arthritis, and a whole line of ailments, not impossible in the younger generation, but quite common in the older generation. There is also a problem of what we call compliance, and compliance means following the directions. And the older person who has, let's say, five drugs a day or more. And that's fairly common for people over the age of 80. As you know, you have these these dispensers where you divide your drugs up over a week period, and you open Monday, Tuesday, Wednesday, Thursday, etc. Section. Uh, that is part of compliance, making sure that the drug is used properly. And used properly, again, means taking it on time. It's almost impossible to maintain a drug regimen where there is a requirement, let's say, to take a particular drug 3 times a day. That's why there is a major pharmaceutical effort to develop and place these drugs within a sustained release, so I don't have to take it once a day. About the only drug that you don't have to hint a person to push them to take it is a narcotic analgesic when they're suffering severe pain. You don't have to remind them to take the drug. But the compliance is a major issue. Of course, cost is an issue, and
let's get back to cost a little later. But
okay.
In regard to compliance, so taking drugs in the prescribed dose at the prescribed time of day, there's an issue with food or taking it on an empty stomach.
Well, there are two primary concerns with drugs that unfortunately are not well understood by a wide variety of the practitioner population, because it requires really a knowledge with a separate literature. One is drug-drug interaction, and the other is drug-food interaction. Drug-food interactions are very common, and you commonly hear grapefruit juice as being as interfering with drug efficacy or safety. And actually, it's an appropriate label to consider grapefruit juice a potential harmful agent when it comes to taking drugs, especially if you're taking multiple drugs. The major effect of grapefruit juice and a lot of other foods are to, one, decrease the absorption of the drug from the gastrointestinal tract, and to increase the absorption of drug from the gastrointestinal tract. You say, well, how can you do both? Well, it can do both. One, by there is what we call a pre-systemic metabolism of drug that occurs inside the intestine. And so what can happen is, like grapefruit juice can inhibit the first metabolic actions of the body on the drug, which allow actually more drug to be absorbed than is planned for from the clinical trials, because less of it is destroyed before it gets taken up. And then that same type of action can occur, that it is not as broken down as readily and as fast as normal, which means that the blood levels can go higher, and it can be harmful, and there are many demonstrations of it. The opposite can happen, where the drug can interfere or enhance the metabolism of the drug to make it less effective, because the blood level becomes less than it should be. But grapefruit juice is not the only issue at hand. For example, milk and milk products with antibiotics is a caution that physicians readily know about, and there are a lot of drug preparations or over-the-counter preparations like Mylanta, Tums, and so forth that have a lot of calcium salts in them for the antacid effect. And those the calcium in those drugs, in those foods or over-the-counter drugs can result in inactivating antibiotics while they are in the gut. So there's that type of interaction. even green leafy vegetables, which are supposed to be very helpful, which of course they are, but they generally contain a high level of what's called vitamin K, and vitamin K is a vitamin that is important in blood clotting. And if you are taking a blood thinner, such as aspirin, or the prescription blood thinners, that it is possible that a very heavy diet of green leafy vegetables can interfere with their efficacy because of the vitamin K, which affects the blood clotting. And we can go on and on. By the way, we can have an entire 2-credit course in a medical school just on drug-food interactions.
And alcohol with antibiotics?
Well, alcohol has a number of interaction problems. One is just the additive effect of alcohol with anything that depresses the central nervous system, like antihistamines, like sedatives, like tranquilizers, like antidepressants. Alcohol can add to the action of all of those. But there is another major problem with alcohol where a drug as non-toxic as we think as Tylenol can become not only toxic, can become deadly, because Tylenol is the active ingredient of Tylenol, acetaminophen, is broken down in the body, and what is one of the metabolites, one of the products of the breakdown of the acetaminophen, is a very toxic metabolite, a very toxic substance that is significantly toxic to the liver. Well, how can we then take Tylenol? Well, because there is a certain class of enzymes and enzyme assistants in the body that immediately inactivate that metabolite. So we don't have to worry about it, except for one thing, is that alcohol is also metabolized by that same group of enzymes and cofactors. And the problem is that if someone is drinking a lot of alcohol, they can use up all of those factors that protect them against that metabolite. And it's not like, not having a Tylenol right after you drink. It can be having a Tylenol after you've had a couple of martinis before dinner every day for a week. It's not a really close time relationship. You can't avoid that type of toxicity by just not having the two, alcohol and Tylenol together. They can be apart, but what's left in the body with excess, not excess, but having drinking a lot of alcohol is that loss of protection against that metabolite. And I have seen, both from a clinical point of view and from a forensic point of view, kids as young as 6 years old dying from that. You say, well, how can a 6-year-old die from having too much alcohol? Well, you'd be surprised. And but there's it is responsible for a number of deaths of liver failure in adults of any age. Anybody who drinks alcohol consistently, not as an alcoholic, which of course would put you in trouble, but just as a 2 martinis before dinner every night is enough to put you in a position where the use of Tylenol in high consistent doses could be very toxic to your liver.
You mentioned polypharmacy before. Can we
Yes,
clarify it a little bit?
it's just taking two medicines independently, and they may each have side effects that uh, in their in the ordinary dose is not a significant threat to the health of the individual. But another drug having the same side effect, of course, they can be additive, or just like in the foods where one drug affects the metabolism of another and therefore the blood level of the drug, um, that 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 can be a serious result. Now, there are certain what we call effect checkers that you can put in two drugs uh, and determine whether they have an incompatibility for adverse effects from all the research that's been done. But the problem in polypharmacy, where you have five, even 10 or 12 drugs being taken at one time, where each drug in and of itself is completely safe, uh, the combination could be unsafe. The problem is we don't have research data that will say, okay, if you combine these 12 drugs, this is what you have to worry about with adverse effects. You can look at the adverse effects of either one of them, of any of them, but together, how they interact with each other can be an entirely different scene.
One of the problems that comes up in a dental practice, since I'm a dentist or was a dentist, is the use of psychotropic drugs uh, in dementia patients and then needing a sedative in a dental office and not having that much experience with psychotropic drugs. How do we handle that?
Well, you handle it the same way as you would handle an automobile mechanic working at an airport trying to take care of jet engines. You don't let them do it. Uh, the fact is that every practitioner, dental, uh, every specialty in medicine, veterinary, uh, uh, podiatry, everybody who has a particular license to prescribe a drug um, has the responsibility to know enough that in that prescribing they're not doing harm. Unfortunately, there's a couple of reasons that doesn't always hold true. One is because the practitioner is ill-informed or uninformed or misinformed, which is not necessarily a blame on him or her, but just because the information is valuable, or two, there is no information really to help them. There's no alert. Um, it's interesting that one would think that once a drug is approved by the FDA, well, that's their job. It's now safe and efficacious. But 20% of drugs eventually end up with what we call a black box warning, where on the inserts, and the other information that FDA particularly approves to be said about the drug from the manufacturer to the practitioner, it's required to be bounded in a black box to make sure that they don't miss it. And 4% of drugs end up being uh, actually taken off the market after being approved because of adverse effects. And you say, how can that happen? Why didn't they know about that during the clinical trial? And the fact is that if you have a serious adverse effect that occurs in 1 out of 10,000 people, your clinical trials aren't going to pick it up unless you're lucky.
You keep talking about adverse drug effects. What are adverse drug effects? How do you
Yeah,
classify,
yeah,
categorize?
yeah. You can say, well, we have side effects and we have adverse effects. Um, A side effect is an effect which you expect uh, to occur, and you put up with it because, in balance against the therapeutic effect, you need the drug. Um, but when that side effect becomes uh, actually harmful to the patient, like a patient driving or operating machinery while being under the influence of a drug that has a side effect of suppressing uh, uh, their ability to stay awake, uh, uh, or some other effect that actually is not just a side effect, but is a significantly threatening health, actually threatens a health disturbance. So if you have a drug like an antihistamine, which could make you tired or sleepy, that sleepiness is a side effect. But if you get in a car and you fall asleep at the wheel and get into an accident, that side effect has become an adverse effect. Or you can have a drug that has an effect on various blood cells, uh, which is in and of itself an adverse effect, meaning adverse, meaning that it can or does cause a health disturbance, or more, or worse, can be deadly too.
Okay, as seniors, you talked about multiple drugs, 5, 10 medications. Suppose as an individual, we feel, hey, we're just taking too many drugs. What can we do about that? Is there a way to minimize this?
That is a very important question because there is now a practice afoot called deprescribing. And deprescribing is an organized response to polypharmacy. And that means that a person goes to their primary care provider, and that primary care provider uh, prescribes a drug. They go to the cardiologist, and the cardiologist prescribes a drug. Then they go to their rheumatologist, who prescribes a drug for their arthritis, and so on and so on. The psychiatrist prescribes an antidepressant. And these things just added, and all of a sudden you have polypharmacy. And now you think, are all of these drugs really necessary? And so there comes now where we look over uh, this patient's a particular uh, role of drugs that they're taking, and you say, is this necessary or is that necessary? That is a relatively recent effort. I mean, not in the past 5 months, but in this millennium, uh, that to look at patients' medication list and do the prescribing of working out what drugs they can do without. So that's a very important question, and it's a question that, in particular, every primary care provider should be asking about their patients who they know are not only seeing them, but are seeing a wide variety of other specialists for uh, just the health disturbance that results because they've been lucky enough to get to be 75 or 80 or 85 or 90 and so forth.
But we shouldn't just stop medications on our own.
Well, no. Stopping medications on your own can have serious consequences. For example, antidepressant drugs. Antidepressant drugs uh, don't work because you take the drug and all of a sudden you get a reaction. Antidepressant drugs work by changing the essentially the chemistry in the brain, altering what we call neurotransmitters, chemicals that carry signals from one part of the brain to the other. Um, uh, but it doesn't occur with a snap of the finger. It takes a while for the brain to adjust to this new process. If all of a sudden you stop taking the drug, it holds a danger because essentially you get caught between a rock and a hard place. You stop taking this drug because you feel you don't need it or you don't like the side effects or whatever it is, but the brain's got to have a chance to come back to normal or what it was before the drug, and therefore, for example, in stopping antidepressant drugs, uh, uh, the, the patient has to be withdrawn gradually. Uh, the same thing is true of steroid drugs. Someone who has been taking what we call corticosteroids, cortisone-like drugs, uh, over a prolonged period at a certain dosage level, their body says, well, since we have all this cortisone-like material coming in from the other side, we don't have to produce it anymore. Well, if you suddenly stop the steroids, stop the cortisone-like drug that you've been taking, and suddenly stop it, the body doesn't quite just really pick up and go back to what it was. It takes a while for it to recover. And during that time, since those hormones are so important for handling stress, one could easily have a stress event that the body can't handle, and it could be deadly, and it is deadly. So when someone is, most people who have been on, let's say, steroids for a couple of weeks because of some acute situation, they'll be instructed, now we want you to go from 5 tablets per day to 4 tablets per day to 3 tablets per day, and give your body a chance to come back and equilibrate.
Is the same true for anticoagulants?
The same is true for anticoagulants, not to the same extent, not to the same extent as cortisone-like drugs or corticosteroid drugs. But yes, again, if you have if you take an anticoagulant, there is the sequence for chemical changes that occurs. It's sort of like it's sort of like an automobile production line, that there are so many different factors in it, and they change depending on where the anticoagulant or blood thinner is working. If all of a sudden you stop that blood thinner, you upset that whole process, and you could end up with what's called a coagulopathy. That is, that your blood coagulates too fast, and that can be very deadly.
On a pragmatic basis, the cost of medications for some seniors is out of hand in this country. Is there anything that the individual can do if they can't afford their prescribed medications?
Well, that's um, I guess I guess that I can only advise that there are people who are a lot more clever than I am in those regards, how to get around it. But um, there is, of course, there are some drugs that are very, very expensive. So you can have a course of chemotherapy for an individual with cancer could cost on the just on an open market, could cost $35,000 a month. Uh, that is generally recognized by insurance companies. First of all, they don't pay what the insurance companies don't pay what the drug companies want to charge on a public basis. They come to an agreement with the insurance company, with the pharmaceutical company, as to what they will pay for the particular drug. What that is pretty much of a secret too often. That you may get you may pick up a prescription at a pharmacy and pay a $5 copay, and then you see that the retail price of what you just picked up is $250. But there there is that the medical insurance under Medicare Part D can be, with recent legislation, can be negotiated even much further. Also, companies that have a non-cancer, because cancer drugs generally fall in a little different category, but in non-cancer drugs, they may have a drug that's used for some type of neurological condition that is, maybe cost $5,000-$10,000 a month, and most of the major companies have particular programs where the patient can receive the drug either free or at a very reduced cost, and that's done primarily at the initiation of the pharmaceutical company. It's not a government program.
Just one other question, and this really isn't related to seniors, except as we may have a daughter or a granddaughter. In the news lately, the Supreme Court has kept Mifepristone and Misoprostol available for now, but a lower court has challenged the FDA's safety, even though it's been on the market for 20 years or so. If somebody listening has a daughter or a granddaughter who is now questioning whether these drugs are safe, what's your feeling?
Well, let's go back to just covering the point from I've dealt with a lot of forensic issues and such. In 1993, the Supreme Court came up with a very important decision. It used to be that we used to say that pigs will fly in a courtroom if an expert says so. So there was a challenge to a particular drug effect, alleged birth defects from an anti-nausea drug, and the point was brought out that the witnesses for the plaintiff, the expert witnesses for the plaintiffs, it's not that they were hired guns, because everybody gets paid as an expert witness for their time. They're not being paid for their testimony; they're being paid for their time. But there are, unfortunately, a number of so-called experts who, like I say, will make pigs fly in a courtroom. So there was a decision in 1993 called the Daubert decision, in which the Supreme Court ruled that the judge is a gatekeeper. That is, the judge can decide whether an expert's testimony is or is not a valid, comes from a valid basis. But the interesting thing is that this Supreme Court decision didn't give the judge the right to decide whether something was safe. It gave the judge to decide whether an expert giving testimony was in fact qualified to give that testimony. So, and could determine the weight to that expert's testimony. So the problem that occurred here is that you had a judge making a decision, but on data that was already known, which was the so-called psychosocial effects of the drug. One thing that was claimed, well, this drug's been on the market for 23 years. Everybody knows it's safe. Yes, everybody does know it's safe, but it should be kept clear, as I pointed out before, every once in a while you get a situation where that a drug adverse effect is so rare that it may take 20 years before it to show up. That's not impossible. It's probably implausible, but it's not impossible. But that's not the issue. The issue with the Mifepristone and Misoprostol is the fact that these both of these drugs, the Mifepristone was the target drug. The effects that the judge was ruling on and that the plaintiffs were claiming were effects that had already been considered. They weren't new effects. They weren't new discoveries. There's nothing new. And the FDA had given it the appropriate safety and efficacy review that was necessary. So there is. I can say this: whether a drug is safe or is not, safety is everybody's own decision. But there is nothing on which that judge based his decision that has not already been considered in the safety and efficacy of the drug. On that basis, there's no difference in safety before or after that decision.
Wow, we covered an awful lot in this discussion. Is there anything we forgot or that you'd like to mention in relation to drugs and seniors?
Well, I think actually the point that you brought up in question about what can we do about it, that if things are going fine, if it ain't broke, don't fix it type of thing. But if they're not doing fine, if there are drug interaction problems and someone is taking a dozen drugs, and it's not uncommon for people over 80 to be taking a dozen drugs, and that what is called now deprescribing, not based on the patient's choice, but based on consideration by the physicians who are treating them. I think that's an important thing to consider and to ask your doctor about. And it may be that the doctor hasn't caught up, but they will as we get more and more into this whole realm of targeted therapy and so forth.
This has been enlightening, informative, and I'm sure the listeners are going to find this podcast extremely valuable. Thanks for coming on, Sorell. It's been a pleasure.
Well, thank you, Larry, for the opportunity, because I think it's important to get this information across.
Thanks again.
If you found this podcast interesting, fun, or helpful, tell your friends and family, and click on the follow or subscribe button. We'll let you know when new episodes are available. You've been listening to Specifically for Seniors. We'll talk more next time. Stay connected.